And now we're going to go through the different cases of ischemia and then infarction. So the most important one for me and for you to understand what is it all about is stable angina, actually. And first we're going to talk about stable angina. So, and what is stable angina? Well, the term is used, you can use stable, it's cool. Remember, stable, stable, stable. Definitely it's not meaning that there's a stable pain. No. Stable means that you can stably, or you can initiate this all anytime you want. If you do some things, if you repeat the things, you're going to have a pain. Because, okay, stable angina means like pain or like squeezing. And angina pectoris means like squeezing pain in the thorax, okay? And the squeezing pain means it's visceral pain. It's visceral ischemic pain, okay? And I don't know if you had a visceral pain, but you're having it. We're having ischemic pain many times, but the visceral one, okay? So it depends. If an organ is ischemic, you're going to sense a ischemic pain. And the difference between visceral pain and a normal peripheral pain is you cannot tell exactly the place where it is, and it's not like sharp. It's more like really like if you exercise too much, if you're gonna do I don't know what push-ups, like 1,000 push-ups, and you never did it before, and then you feel this pain, the muscles like soreness or whatever. This is what they describe. Fortunately, I cannot tell you exactly. I still didn't experience this feeling, fortunately, but someday I will, I guess. Depends. Okay, but anyways, so it's a pain inside. It's over here. If you say angina pectoris, you mean already historically you are talking only about ischemia of myocardium. Okay, so myocardium is ischemic. That's important. Yep. Nothing else. It's defined like this. If you would have ischemia of lungs, no, you won't call it angina pectoris, although it hurts in the same place, in a chest, okay? So angina pectoris means it's only myocardium, which is ischemic, and you're sensing a pain from over there. But the important thing is, hey, watch out. In US, if you say he has angina, everyone knows it's angina pectoris. But maybe even in Israel, I don't know, but I'm sure in France, in Czech Republic, I guess in Germany, I'm 100% with France, that we say angina. And if we say angina, because this is this sore sensation, we mean sore throat over here in Czech Republic. So watch out. So that's why over here you have to say yes, angina pectoris, because then you say, oh, it's not the sore throat. It's a sore sensation of from the heart. Yeah. So watch out that. How is it in Israel? You say angina. Do you use the term?
It depends. It depends on your roots.
Oh, okay, yeah. So, and how is it in Russian then?
Yeah, in Russian it's angina.
So in
Yeah,
Russian it's
so
angina, it's what you said.
I'm very sure that in the Eastern Bloc uses angina like one word for the sore throat.
I know when my parents says angina, they don't mean to chest pain.
Yeah. So watch out on that, okay? But anyways, then everything is just a definition. But the thing what you should understand and what you should imagine under stable angina. And why stable, the term? Well, why? Because you can initiate
because it's irreversible, isn't it?
It's reversible, of course. It's ischemia. Both of the any angina are ischemias. That's important that you should understand. But this one is a special one, which you can really easily diagnose just by testing, and that is that this patient has a pain only during load. So If the heart has to pump more, now they feel the pain. If they're not doing anything, they're fine. So every time their heart, because of whatever, because it's stimulated by the sympathetic trunk, and just brain tells it, go faster, and the heart goes to tachycardia, suddenly at some point, they're having a pain. So it's a pain on load. So every time they run for a bus, oh, now they're having a chest pain. But when they calm down, the pain disappears. That's important. Okay? So it's stable, and you can always say, oh, it's only doing load, it's a stable angina. And stable, really stable, you can use as you want if this is a coronary artery. I will make it bigger. Or I can make it like that. So this is a coronary artery. And still, before that, stable means stably you can. So if you put someone on a treadmill and tell him to walk, he walks, and now he's having a pain. He gets off, he calms down, and the pain disappears. And you can repeat it as many times as you want. That's stable in this way. Then it is stable because it stably reacts to nitrates. So every time they use nitrates, the pain disappears. It works very fine for them. What else? This is crucial, and already we're heading to ECG. Remember, every time they're having a pain, and if you could put them a leads on a treadmill, then what happens is there's a depression. Very likely there's going to be depression of the ST segment. Nothing else. Only ST depression. Mainly. That's important. There is, for example, remember I will tell you later, there is no coronary T. No coronary, only depression. And what is cool, it stably normalizes when the pain disappears. So it just goes down and up. And you see it on ECG. Okay? After some, it's not working 100%, but in most of the cases. Okay? So this pain comes and goes with the load. And how can you explain this? How come? Well, it's very simple. And I already draw a coronary artery. And you know what? What are they having there? And you should say in general always narrowing. That's important. And the narrowing is more than 70%. This is a magic number you should remember for today. Okay? If there is a 70% narrowing, very likely, and you know what? In any artery, not only coronary. If we talk very general, if you have narrowing anywhere in the body and it's more than 70%, the flow is pretty okay if the tissue is not loaded somehow. But if it needs to work more and needs more perfusion, the 70%, let's say, narrowing won't fulfill that. So basically, what you should imagine over here, it's narrowing, okay? That's important, narrowing. If you could see the coronary artery, this is what it explains. The narrowing could be also due to compression. The artery could be beautiful, but if you compress it from outside, it's just the same. There's a narrowing inside. But in most cases in humans, it's atherosclerosis. But the plaque is also stable. It's a nice plaque. You like this plaque. Okay? And this explains everything, because look at that. If the heart is not doing anything, you don't have ischemia. But at the moment, when you run somewhere or anything starts your heart to pump faster, then it's a muscle. It needs to pump more. Anything that triggers to increase the cardiac output means that you're loading the heart, because it needs to pump more. Thus, it needs better perfusion, higher perfusion. But this narrowed artery, which I could draw as this as well, it could look like this over there, is not able to supply the tissue during load. That's why you're starting to have ischemia behind the narrowing. Yeah? But you get off, and now you're sensing pain when there is ischemia. You get off, you calm down, and what? The pain disappears. Okay? Yeah, so then it's beautifully, again, reperfused. I don't know what to color, so blue. It's reperfused. And so when the coronary artery has a time when the load decreases and the coronary artery is able to wash the waste products and everything, the pain disappears. And this just explains the triggering of the pain. During load, it comes. You stop doing what you're doing because it hurts, you're afraid. Depends. If you're too stimulated because you're afraid, yeah, maybe you won't turn it off as fast. But that's what you want to do as soon as possible. Calm down, okay? And the pain is going to disappear. But if you would force someone to go over the pain on the treadmill, guess what? You're going to prolong the ischemia, and he's going to end in myocardial infarction, of course. Yeah? Okay? So the sooner you stop the load, the better. But you know what? Why I'm telling this? Although on stable angina, you should look like a nice angina still, and you don't worry so much about it. They get nitrates, and because giving a stent to over someone, it could be a more pain than anything else, because then they have to be on drugs. Remember, anything you put or do with the coronary arteries invasively means you increase the risk of formation of a clot. You're putting an artificial stent over there. So that's why you rather wait till they worsen or something, because they don't have to. If they never used the drug before, it's better for them not to use anything. Okay, it's always debatable in a way. But you know what is why even these people are so much at risk? In what situation? And we talked about it. Every time when you're not able to turn off the increased heart rate. And that is, for example, in anemia. In case a patient with angina, which means he has already ischemic heart disease, is in anemia, the only way for him to compensate the anemia is by increased heart rate. Because if you're anemic, 1 liter of your blood is able to transport much less oxygen than if you would have normal amount of hemoglobin. So the compensatory reaction to this is tachycardia. And in this case, how you want to turn the patient off? He's like running like hell, although he's laying on a bed. And these people sooner or later will have infarction. And that actually, remember, most of the people that are anemic will die on heart attack, because you are overloading the heart continuously. That's why, remember, if your grandparents and any of your older patients, if they have ischemic heart disease and they come with anemia, you immediately normalize the anemia. Basically, in all patients, you want to normalize anemia as soon as possible. If there's a young patient, 20 years old, with anemia, he's fine. He can survive this in a way. So you have time. But the more ill patient with different diseases to it, the sooner or immediately try to normalize the anemia, because you're going to calm him down. You won't overload the heart. Okay? Yeah. And the same comes with hypovolemia. If someone is bleeding and he's 20 years old, he's okay. But if someone is 80 and loses pressure because he's bleeding, you better expand it as soon as possible, because he's going to have a heart attack. So that's what you should remember about stable angina, that there is a narrowed, stable plaque, nice plaque, which is nice, smooth. I don't know if you know Zohan, but it's still fun for me after so many years. But so it's silky smooth, okay? It's silky smooth plaque, okay? Silky smooth, nice, good. But anyways, so I give you an analogy. It's just the same. These are femoral arteries, okay? And if you got narrowing 70% over here, guess what you're going to have? It's just the same. It's completely same analogy. That person with this wakes up in the morning, goes on a street, then he walks on, and now he's having a pain. Okay? And it's ischemic pain. And why? Well, because this is 70% narrow. So if this is the right leg, he's ischemic on one leg, and he stops. And when he stops, the femoral artery is able to wash out the waste product. The pain stops, And then he walks again 300 meters, and then pain comes again, and he stops. And you call this claudications and claudication. And that means limping. He's limping because of pain. And you normally ask the patient how long you can walk before you stop. And you write 300 meters, okay? And you know here's a problem on his femoral artery or somewhere lower, somewhere, okay? And you can go on with this. You can have this on a mesenteric artery, okay? In some cases, old people. So there's an atherosclerotic plaque or narrowing in general of this artery. So guess when they're having pain? When they eat something. Because now the guts, they need like perfusion. Whoa. And it's the system is not able to supply it. So there's ischemia in the guts. And basically that's the reason why they don't eat. Okay? And you can go on and on. Okay? Yeah. But of course the most important artery in this respect, because that's the pump that keeps you alive, is the coronary artery. Okay, if your brain artery is occluded, of course, okay, then we could polemize what is more important, if a brainstem artery. Well, that's debatable, okay. But if we talk about other arteries somewhere on the cortex, up on the cortex, okay, it's going to be closed. You won't move with your legs, arms and legs, but still you're going to be alive, okay. But if your heart stops, you're going to die very, very, very soon, okay. So from this respect, I'm not talking about brainstem specialities, but that is not as common as heart attack, okay. Yeah. So, and now we're getting to unstable angina. Unstable. And already from the term, you can tell it's worse. It's unstable angina. And unstable angina means what? It means that the pain can be during load, but you don't care about this at all. You care that the pain comes and goes, and you never know when. You care only about the attacks which are when you're doing not anything. So basically, it's not on load. You never know when it happens, and suddenly it happens. You really don't know what's going on. You have a pain. You have just the same pain as someone would experience with stable angina during load. But how can you turn off this load? This pain. How can you turn off this pain if you're sitting in a chair and not doing anything? Once I said, and I'm repeating this joke all the time, once I said you're sitting in a chair and watching a soccer game. Okay, for someone it's a big load, okay? So that's a treadmill for many people. So that's not a good example. Good example is you're sitting on a chair and you're not doing anything, and suddenly pain comes. And basically with nitrates, yeah, they can sort of help, but they're not as efficient as in the stable angina. But how can I calm myself down if I'm not doing anything? You cannot. So basically these people don't know when the pain's going to be gone. But remember, typically the pain lasts like minutes. 5 minutes, 1 minute, 2 minutes. If it would go on and on over 20 minutes, it's really not only ischemic pain. It could be rather also already in infarction pain. And you cannot tell the difference. It hurts the same way. The only difference between ischemic pain and a pain when you're having during heart attack is that the one with heart attack stays longer. Okay? It won't disappear in 1 minute, 2. It's going to go on. But also it won't go on for a long time. This is important already. It's going to you got endorphins, everything, so it's going to disappear like in it's worse in the first minutes, and then it goes on and it stays maybe 1 hour, and of course then he gets opiates and everything and it disappears, the pain. Okay? So this is very important with the dynamics of the pain. In case the pain lasts 2 days, it's not MI. It just comes, it's sudden now, and then in 1 hour it's much less or nothing. Okay? That's important. Also, if it's a sharp, identifiable pain, it's not ischemic pain, or it's not a pain during infarction already, where there is, you can call it ischemic pain because it's the It's the same. It's just the same trigger. It's the same. There's no difference among the trigger. It's because of the chemical changes in the tissue are what it triggers it on. But if it's really, if you say it hurts here, exactly, it's not a visceral pain. So it's rather not infarction. Also, if it changes with position, that's very important. If I bend forward and it hurts and go back and stops hurts, it's also not MI. That's very important. Or ischemic pain. It's not angina or MI, because this tells you there's something rubbing or something, or it's the pain. You should imagine if you're having ischemia now of the heart, it shouldn't change with position, the pain. If there's ischemia and you won't change it if you put your head down or whatever, okay? So if it changes with position, it's sort of good. It's not MI, rather, okay? So remember these small rules, okay? Yeah? And what is important, yeah, if it's below 20 minutes, and this is very uncertain, you never can be sure, but it's rather unstable attack, okay? But to be clear, and that you can imagine what happened over here is, what happened over here? What is behind the sudden pain you never expected, because you're not running for the bus, you're just sitting down, and now you're having a pain and you don't know how to turn it off, but it stops. Well, the explanation is simple, and now we know more and more that very likely it's a rupture of the, and this is not a silky smooth atheroma. This is an alpha one, already with ulcerations and whatever. And what happened? It ruptured. It ruptured, bursted, and also thrombocytes it over here and everything, and it occludes the vessel. But the cool thing is it occludes it only for a few minutes or seconds. Rather minutes, few minutes. And when it occludes the vessel for minutes and then it gets dissolved very fast, you were lucky. Because it didn't take so long and it was only a ischemia, okay? But as you can see, with every attack, with every other rupture and bleeding into the atheroma, you are coming sooner or later to the point where it will not dissolve. And you're going to have MI, okay? And basically, yeah, some people are really unlucky that they're fine, never had an angina, and suddenly, boom, ruptures, the plaque ruptures, and it won't dissolve, and you're getting right into MI. And some people, yeah, the arteries that get, or coronary arteries, they get narrower, and now they're having angina pectoris, only with load. And then suddenly, from one day, it starts to be like not only during load, but it worsens, and then you're switching from stable angina into unstable angina. And from unstable angina to MI, it's just one very, very small step for you and for the heart as well, okay? There's no difference. Yeah, if you're having heart attack, you have a big problem, okay? Small step for a big problem, okay? Yeah, very tiny step. So basically, what do you do with, in contrast to stable angina, with unstable? You basically sort of think of it as a future MI, and why to wait? So you don't wait. It's not like acute, but you should really test it, and then if it's really unstable, you put a stent there. Why would you want to wait for a real MI, okay? And it's always, this is very like debatable if to put it there or not, yeah, but definitely, yeah, put it there, of course, yeah, put the stent there, yeah. But at the point when you give him a stent, then he has to be on aspirin and clopidogrel, etc. So now he uses other drugs, and it's always debatable, because if you're old, you have many other problems, and maybe you had a stroke yesterday, which was a bleeding stroke. Well, that's very debatable if to put aspirin or not, etc. So then you have to take the person and look about his other problems, and yeah. But certainly, if you get a stent from this point, if you were not on drugs, you have to eat drugs every day, and it's it's problematic for some people. For me, it's really hard to take antibiotics. I like not to forget to take antibiotics like every 8 hours. It's really, I always forget. Okay. From my perspective, yeah, I'm heading to a horrible times sooner or later, earlier than you, being on drugs all the time. Okay, but maybe if you eat 10 in a row in the morning, then yeah, maybe I won't have to eat breakfast then, but depends. Anyways, so unstable angina means it suddenly ruptured. You cannot say when it happens or not, and it's one way to MI. So watch out, you rather put a stent soon. But what about ischemic attacks? Well, it's just the same. You will see depression of an ST segment and no T's, no coronary T. Definitely you shouldn't see coronary T there, but there are always, with ECG, remember there are always exceptions. You cannot take ECG like 100%, never. It just helps you to know, but like with anything in medicine, or most of the things, crucial for you is the patient's history, how it happened, and clinical signs. That's so crucial for you. It really can tell you everything in most of the cases, okay? But this very much supports the idea. Like, it's obviously first thing always you do there, if there's something with heart, remember that it's ECG. Always, 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 always. Pain somewhere in the chest, ECG, and then you can think of something else. Okay, so ST depression, yeah, during the attack. Get it? If the narrowing in case of unstable angina is serious, over 70%, they're going to have pain during the load, obviously. But you don't care about this, forget that. If they're having sudden pain with no load, that's unstable angina. Also, basically, when someone comes to you, and this is the first thing he says, I had an attack, you never met him, I had a pain over here, it disappeared. You always put him first into unstable group, and then when you test them on a treadmill and you see it's only like load angina, the stable one, you regroup him to stable. Just not to forget that it could be this serious unstable angina. Okay? So unstable means worsening angina. It means one way, one step to MI. It means that the plaque is awful and will rupture again, and this could be the last rupture. With every rupture, there's a higher and higher risk of being fully occluded. Okay? Well, and there's one more angina, a special one, and it's exceptional one, Prinzmetal's angina, or you can call it variant angina. Okay? And this angina is special. Remember, it's mainly in women, young women. And the paradox over there is you do angiography. If you do angio in these two, they have awful vessels. And not only coronary, but atherosclerotic processes everywhere. So don't forget, carotid is going to be like also awful, and femoral arteries, and that all around the body, and the cerebral arteries. Okay, so it's everywhere like this. If you're having if atherosclerosis is bad on your coronaries, the same situation is everywhere around in arteries. Remember, there is no atherosclerosis in veins, please. Never, ever. No one ever described atherosclerotic process in veins. Remember that. Okay? Yeah. In pulm, it's about pressure. It's a higher pressure system than veins. That's why you got atherosclerosis there. You can have also atherosclerotic plaques in pulmonary artery. It was described, but it's artery again. Okay, it's the one which worked with higher pressure, but although 30 torrs, which is higher than normal, 30 torrs is not so much. But yeah, it was described. But remember, only arteries. And you got a big group of arteriosclerosis that talks that the artery is fragile, do whatever. You can have a concrete concrete, I mean, like, you know, like the one you use for building houses. So concrete in your, if you're having it in the vessel, it's going to be hard vessel, and you can put it in the group of arteriosclerosis, yeah. But if it's atherosclerosis, that means it's the cholesterol. Those are the foam cells and everything over there. Okay, so remember, please, you got arteriosclerosis, arterio, and that's whatever the cause is, that the vessel is hard, artery is hard. And then you have a biggest subgroup of it, and that is athero. And that talks about the cholesterol, atheroma, okay? The most common cause in humans of arteriosclerosis, okay? Yeah? But anyways, I just detoured somewhere else. But go back to Prinzmetals. In case of Prinzmetals, you do it's a sudden attack in women, young women mainly, also men, but mainly women. And you do angio and you see there's nothing. They have a beautiful coronary arteries. And girls over here, you are very lucky. Remember, if before your menopause, basically, if you're having a pain on the chest and you're still ovulating, you are pretty much protected. So it's very unlikely you're having heart attack. But at the moment, as this turns down, I mean the menses, then your risk is just basically the same as men. So basically, when a 50-year-old woman and she's still menstruating comes to having an MI, it's unlikely. Okay, it's there. Sort of, you can think of it like this. So this is very. Again, as I said, clinical evaluation and all the things you know about the patient are very important. That will help you. Okay, but anyways, Prinzmetals means it's a vasospasm. Very likely. We think it's a vasospasm. It's just temporary. It causes ischemia. But you know what is paradoxical or totally like different over here? During the attack, if you can put leads on her and she's having the attack, she's going to have ST elevation. Okay, maybe not as big one. I don't want to exaggerate here. Well, no, that's not good. Okay, she's gonna have ST elevation. 2 millimeters more than over the line is already ST elevation, yeah, on a chest lead. Okay, but 2 millimeters higher. That's and she's having ST elevation right there, and then it goes down again when the pain disappears. This one is special. I'll tell you the explanation why later. Okay, good. So, thanks for watching, and don't forget to subscribe and ring that bell. And as always, check the description below for supplementary questions and other materials.